Hi, my name is Dr. Ersu, Refika, from originally from Turkey, but now living in Canada, working at Children's Hospital of Eastern Ontario. Today we'll talk about polysomnography. I hope you can both hear me and see me well. Please let me know if there are any issues with either the voice or the slides or the screen. So the polysomnography will be based mostly on narrative slides, but I do have some MCQs just to kind of make it lively. And I think it's maybe best to discuss the questions at the end. But if there are any pressing issues, please type into the chat. So the rules that we use are based on the American Academy of Sleep Medicine manuals, which was initially published in 2007, and then in this paper updated quite a bit change in the rules in 2012, and since then it has been updated almost every year. The last important change was in 2017 for children, and it's been updated recently in 2020, but not many changes. I have no conflict of interest. So we'll discuss the indications and the elements of polysomnography. We'll look at the scoring of sleep briefly. It's a very detailed scoring system, but I think it's important to know what kind of scoring at least we use. It's important to know. And then we'll maybe focus a little bit more on respiratory events scoring during sleep and talk about normal values and what the elements of a sleep study report is. So we briefly talked about yesterday, polysomnography is a test to determine the diagnosis and severity of sleep disordered breathing in children. There are some alternative methods, and during questions, maybe we can also talk about that. It basically means taking lots of polygraphs during sleep. So I'll start with a question. So I'll ask you guys, which of the following is not an indication for polysomnography? When there are residual symptoms of obstructive sleep apnea post-adenotonsillectomy, when clinical assessment suggests sleep-related hypoventilation due to neuromuscular disease, for positive airway pressure therapy titration, for children with chronic lung disease, following adenotonsillectomy for residual OSA in children with high risk. Which of the following is not an indication? So next we'll discuss in some slide what the answers are once we have the result. But I think it's good to think about the indications as we're doing this question. Okay, so perfect. 61% had answered as chronic lung disease, which was the correct answer. So there is a paper which was published in Sleep Medicine in 2011, just summarizing the indications. Some of them we may agree, some of them we don't, but those are the indications that we usually base our polysomnography studies. So if there is a clinical assessment that suggests the diagnosis of obstructive sleep apnea, it's indicated, but we discussed yesterday in some cases, we really maybe don't have to, especially we have limited resources. And then if there are residual symptoms of obstructive sleep apnea following adenotonsillectomy, to see if you really need to treat the child for obstructive sleep apnea in the case of continuing snoring or daytime sleepiness. And this paper recommends doing a polysomnography for children who are at high risk after adenotonsillectomy. independent of the symptoms. So this is a little bit questionable because and this was asked during the chat yesterday, so do we need to do a sleep study in every child who has obesity after adenotonsillectomy, let's say if the child doesn't have any symptoms? I think in clinical practice, we don't, at least in the centers that I have worked, but maybe in children with Down syndrome or Prader-Willi, because they may also have some central apneas that are remaining that may not be detectable with clinical exam or clinical questioning. So those are the children that do need a follow-up study. Then for positive airway pressure titration, especially in the beginning, it's helpful to titrate and help the children to tolerate it better and not using lots of pressures. If the clinical assessment suggests a congenital central hypoventilation syndrome, that's the diagnostic method we use initially. There is, of course, the genetic diagnosis as well. And then if we think there is a hypoventilation or sleep disordered breathing in a child with neuromuscular disease and chest wall deformities. Some selected cases of primary sleep apnea of infancy, or now called BRU, previously called ALTI cases. If we suspect of obstructive sleep apnea, then it's indicated. And for chronic PAP support, especially if there's a change in pressure requirements, and also if there are additional or alternate treatment to see if the patient still needs a PAP. For example, you have a patient who is getting an orthodontic treatment in addition to PAP to see if maybe patient doesn't need the PAP anymore. You can do a diagnostic portion. And then for orthodontic treatment, after treatment with rapid maxillary expansion, it's good to know if the obstructive sleep apnea has resolved. It's recommended. Children on home mechanical ventilation with tracheostomy, for follow-up, this is again a question. Some centers just do a cardiorespiratory monitoring with saturation, recorded saturation, and end-tidal or transcutaneous CO2, which is of course acceptable. And sometimes it's recommended to do a polysomnography by some papers prior to the cannulation of the tracheostomy. Some centers, again, just do gas exchange monitoring. There are some papers saying that you can miss some obstructive apneas if you just do gas exchange. So if you have a child with chronic lung disease, you only require a sleep study, a polysomnography, if there's a clinical suspicion for an accompanying sleep-related breathing disorder. So a child with cystic fibrosis or bronchopulmonary dysplasia and so forth. So these children, if there's a suspicion of hypoxia or hypoventilation during sleep, not related to obstructive sleep apnea, you can always do gas exchange monitoring. So I think we always need to see and think about, do we really need the polysomnography, because it's a very limited resource. So during a polysomnography, the elements of polysomnography are, of course, the air flow. So with airflow, we use a thermistor for apnea detection. And it's recommended to use a nasal cannula, a pressure cannula, to detect hypopneas. But if you have only one of those, then those can be used as a surrogate marker. Then we look at of course, if you want to decide first if the child has apnea or not with the airflow. Then you want to see if it's an obstructive or central apnea. So you look at the breathing effort, so chest and abdominal belts. So those are recommended to be used with a respiratory inductance plethysmography technique. And then you also want to see if there are any desaturations related to those respiratory events, and also if there are any hypoventilation, high CO2 levels. So you can do this whether with end-tidal CO2, with both end-tidal CO2 and or transcutaneous CO2. So those are the things that we use to look at the presence of apneas, whether they are central, obstructive, or mixed, and whether they are associated with desaturation or high CO2 levels. We also, so these are also checked with, these are also done with a polygraphy at home or in the hospital. So in addition, in the polysomnography, we have the EEGs, EOGs, and the chin EMG. So those are the ones that we use both to stage sleep, so whether it's stage non-REM, REM, or which stage of non-REM sleep, and also to look at the arousals. So those arousals give you a sense of how disrupted the sleep is. We look at the ECG to see if there are any arrhythmias, and then we can do some ancillary channels, so leg EMG, for example, to look at the periodic leg movement, which we'll not talk about today. So two advantages of the in-laboratory overnight polysomnography is that there is a video camera recording. So if you lose a channel or if you want to see how the breathing of the child is, you can always look at the video recording. And you also have a sleep technician or sleep respiratory therapist or a nurse who's following the child to make necessary adjustments. If there's a lost signal, to go fix it, and also to take notes. For example, if the child's chin is working crazily and the technician is putting a note saying that the baby is sucking on a pacifier, then you're not wondering what's going on to that child. With that child. So when we have a polysomnography, we have this sort of 30-second epochs that we review the next day or in a couple of days, score both the sleep and then the respiratory signals. So we look at which stage the sleep is. You look at the ECG snoring, and we look at the airflow with nasal with nasal cannula and the thermistor, and we look at the chest and abdominal movements, transcutaneous CO2, end-tidal CO2, saturation, and the carbon dioxide wave signal from end-tidal CO2 also gives a surrogate, although it's not recommended to use as an airflow signal, gives a surrogate of the airflow signal as well. And it's important, especially in children, I find, to have a plethysmography signal for the pulse oximetry. So if it's not picking up and you don't have a good signal of the saturation, you're not incorrectly saying that the child is having these saturations. So now we'll go to the sleep scoring, and I have a question for you. So which of the following is true for sleep staging in children? Sleep staging is not important for obstructive sleep apnea diagnosis. After all, we decide on the respiratory signals. Sleep usually starts with REM sleep in children. Most of the sleep is spent in non-REM stage 3 in children. Arousal is an abrupt shift in EEG frequency lasting for more than 3 seconds. And lastly, non-REM sleep increases in length towards the morning. So we wait until at least 50% of the participants have answered the questions. So we'll wait a little bit more. So maybe the sleep staging is important when we look at the whole picture, and maybe not so important for the purpose of this workshop, but still I think it's worth mentioning. So I'll have some slides. Yeah, so well, still 47% answered this correctly. So the arousal is an abrupt shift in EEG frequency lasting for more than 3 seconds. And I'll review in the next slides the answers to the other questions. Is sleep staging important? It's important to know if the child had enough REM sleep, where the period for the worst obstructive events happen for children. And the studies in children show that there is a first night effect, although it's not a greatest effect on sleep disorder breathing. If the children come to the sleep lab, it's their first time in the sleep lab, and they don't sleep well, and they do not have enough REM sleep, we may miss some mild obstructive sleep apnea, and in rare cases, we may miss a few moderate obstructive sleep apnea even. So it's recommended to do maybe another sleep study or just go to the treatment if you're not seeing enough REM sleep and you don't see obstructive sleep apnea in the first night in the sleep study. So the sleep stages are based on different qualities on EEG, chin EMG, and EOG in children, and I'll review that in a few minutes. And it's also important to look at the sleep architecture. And this is an older study, but just shows that most of the apneic events, so 55%, happened, obstructive apneic events happened in during REM sleep in children. So we use the visual scoring pediatric rules. So when we review a sleep study based on the rules that I just mentioned in the American Academy of Sleep Medicine rule book or a guidebook, we look at the sleep and we visually score based on the EEG, EOG, and EMG. But after 2 months of age, post-term, because in the first 2 months it's different. And for the interest of time, I didn't go into the infant scoring, but if there are any questions, I'll be happy to try to answer. So we look at sleep stages in stage wake, and non-REM 1, 2, 3, and stage REM. And in infants less than 6 months of age, sometimes it's not easy to differentiate between easy or possible to differentiate between N1, N2, and 3. So we can just stage them as stage N. So the sleep cycles start first being by moving from wakefulness to non-REM sleep. So the answer to the second, maybe the question, the first, second question is, sleep starts in non-REM sleep in children, but not in infants. So in infants, it may actually start in REM sleep, which is normal, but beyond infancy, beyond usually 6 months of age, if sleep starts with REM sleep, it's suggestive of a diagnosis of narcolepsy. It's actually one of the criteria that we use. The first REM sleep then follows the first non-REM sleep, usually around 70 to 90 minutes after sleep onset. And those two sleep states, non-REM and REM, alternate in 90 to 120 minute intervals. And normal sleep usually consists of 4 to 6 non-REM REM sleep cycles. And as the night progresses, REM sleep periods increase in length. So that was also asked in the question. So if we wake up the child really early in the morning from the sleep lab for them to go home, we may actually miss some good opportunity of REM sleep, maybe which may show actually some obstructive events. So non-REM sleep predominates in the first half of the night to repeat, and one is usually called transitional light sleep. That's usually how we start sleep, and around 5%. And 2 is the most time we spend in sleep, around 50%, and not N3. And N3 is usually 20% of sleep. Why are we interested in sleep as respirologists, pulmonologists? Because sleep has a profound effect on breathing. During non-REM sleep, we have central depression of breathing, regular timing and amplitude, decreased chest wall stability, and there's usually mild hypoxia and hypocapnia even in healthy children. So this is relative to wakefulness. So in children with lung disease or with upper airway abnormalities, these become even more profound. In stage 1, when we look at the EEG, it's low amplitude, so they are short waves, they're not tall, and mixed frequency, so they're not so fast or they're not so slow. There are no spindles or K complexes. These are the characteristics of sleep stage non-REM 2. And the EEG shows slow rolling eye movement, EOG shows slow rolling eye movements, and EMG is lower than awake, but EMG is lowest during REM sleep. And in stage 2, where we spend most of our time sleeping, there's at least one sleep spindle. So those are the sort of fast and low amplitude waves, and K complexes. And EMG is again lower than awake. In stage 3, it's very easy to differentiate. There are high amplitudes, so tall alpha waves occupying greater than 20% of the epoch, and EMG is again quite low. And when we look at the REM sleep, there's also called dream sleep, nightmares, dreams, and usually predominates in the second half of the night, like we just mentioned, and usually occupies 20% of total sleep time, and it's most vulnerable time for the respiratory system. Because the sleep is not, the breathing is not controlled by chemoreceptors and is irregular in timing and amplitude. And there's a marked inhibition of skeletal muscle tone, but except for our diaphragm, which is the main muscle of respiration, as you know, and extraocular muscles. And there's more marked hypoxia and hypercapnia. So the gas exchange abnormalities is more profound during REM sleep. And the hallmark of REM sleep is those rapid eye movements that are phasic, and they're also the very low, the lowest EMG tone during sleep. The EEG shows sort of mixed frequency. Sometimes they are called sawtooth waves, or maybe they look like a sawtooth, mixed frequency, and they're low amplitude waves. So I think that's about it for sleep staging. And I just want to mention arousals, because we use arousals for scoring respiratory events. So they are described as abrupt shift in EEG frequency. So as you see here, there's an increase in EEG frequency, and it needs to be lasting at least 3 seconds in duration. So those are also scored when we are scoring sleep. So when we go to the sleep architecture, so when we go to the sleep architecture definitions, when we look at the sleep study, we mark the lights out, lights on, or the technician does that for us, total bedtime, and then total sleep time. We also look at the wakefulness after sleep onset. So sleep latency is an important measure. It's the time from lights out to sleep onset, usually 25 minutes in children. REM latency is the time from sleep onset to the first REM sleep period. So if this is too short, so beyond infancy, less than 15 minutes, then it's important for consideration for narcolepsy. Sleep efficiency is also calculated from total sleep time divided by the total bedtime. And in children, sleep is usually very efficient, greater than 89% of the bedtime the children usually sleep. And then we look at the percentages of each sleep stage occupied during the total sleep time. And we also look at the arousal index, which is a measure of sleep disruption. And again, it's around 9 in children who are healthy. So now we'll go to the respiratory event scoring, and we'll start with a question and think about how we score respiratory events in children. So which of the following is true for respiratory events in scoring in polysomnography? Central apneas lasting less than 20 seconds and not associated with desaturations are common in children. Obstructive apnea is scored when there is no flow in the presence of breathing effort and the event lasts for 5 seconds. Mixed apneas always start with central apnea followed by obstruction. Hypopneas are scored when decrease in airflow is followed both desaturation and an arousal. Hypoventilation is present if greater than 5% of the total sleep time is spent with a PCO2 greater than 50 millimeter mercury. So please vote. Okay, okay, excellent. So we'll now review all of these, but 31% correctly answered this question. So central apneas lasting less than 20 seconds and not associated with desaturations are quite common in children, so we do not score them. So we'll start with scoring of central apneas during a polysomnography. So we score central apneas if there's no flow, and there's no ribcage or abdominal movement. But those that are last less than 20 seconds and not associated with desat or arousals are quite common. So we score them if they last more than 20 seconds, whether there's an arousal or desat or not. Or if they last 2 respiratory cycle pause and associated with a desaturation or an arousal, we score them. So the thought here is that they are either they are too long, that they may be significant, or they are long enough, but also associated with a physiological consequence. So the 2 respiratory cycle pause came about with the American Academy of Sleep Medicine book, because before we were using actually 5 seconds, 6 seconds, sometimes 3 seconds. Different studies just picked different numbers, but it made sense to normalize the breathing pauses based on the age, because a child who is 6 months of age has a very different breathing rate compared to an adolescent who is 13 years of age. So now it's for every respiratory event, we use 2 respiratory cycles. So how we calculate is that around the beginning, maybe the beginning of the sleep, we look at the respiratory rate and then see how many seconds is 2 respiratory cycles for that child. And then during the study, that's how we score the respiratory events. So the DSAT 3% is accepted in children. In adults, it's 4% or 3%. In children, it was initially like that, and then we went back to 3%. And there was a question yesterday about oximetry. Oximetry studies unfortunately used 4%, so it's not consistent, but with polysomnography, we use 3%. Or an arousal, because these are physiological consequences. So in 2017, there is also now a new, since 2017, there's an infant rule. So they also recommend, the American Academy of Sleep Medicine recommend to score if it's 2 respiratory cycle, the pause, and there is a bradycardia associated with it. So this rule is rather new and we just started to use, but I think it's important to know. So that's how central apnea is seen. So there is no thermistor flow, or there is no abdominal or chest wall movement, and there's a desaturation. So if you can see, there is the saturation was around 96, went down to 92. So this is, although this is not 20 seconds, this is more than 2 cycles for this child, and it's associated with a desaturation. Not with an arousal, as you can see in the EEG here, but since it's associated with a desaturation, it's actually scored. So I just see from chat there's a question, what age can you apply the adult rules? So it's recommended to apply the adult rules for children older than 13 years of age. There are still some questions whether we are, because they're quite different, and we can maybe I can touch upon the adult rules as well. There are some questions whether we are underestimating. So it's recommended that if you're using adult rules in children older than 13 years of age, use 3% of desaturation rule, not the 4% desaturation. So going to periodic breathing. So periodic breathing are central apneas in a row. So here you see a flow and thermistor signal. So to call this periodic breathing, you need to have more than 3 respiratory pauses. So there are 4 here. And they need to be all lasting more than 3 seconds. So these are more than 3 seconds. And there should be less than 20 seconds of normal respiration between pauses. So if you had one here, another one here, and then another one here, after 20 seconds of normal breathing, you wouldn't score that as a periodic breathing. So periodic breathing is normal, especially in preterm infants and young infants. The 5% is normal in term infants, 5% of total sleep time spent in periodic breathing. And 10% is normal for preterm infants. So if you see, although 5% is normal, if you see maybe an adolescent with 6%, 5% of periodic breathing, you should always think and look for underlying neurological problems, even tumors. So periodic breathing is worrisome for older children. And if you see abnormal levels in babies, then you need to make sure you follow them. So when we come to obstructive sleep apnea, there is no flow, and it needs to last for 2 breaths again, in the presence of rib cage and abdominal movements, and they usually become paradoxical. So here you see they are parallel, and then once you have the apnea, they become paradoxical, and it's important to know that there is no desaturation or arousal rule for obstructive apnea, because they are important events in itself. So no flow lasting for 2 breaths in the presence of rib cage and abdominal movements that are usually paradoxical, you score obstructive apnea. So this was a child we followed when I actually was working back in Istanbul at Marmara University. There was no flow in the nasal cannula or thermistor in the presence of thoracic and abdominal movements. And the patient probably had an arousal here. I don't have the EEG here. And then took normal breaths, couple normal breaths, and had another obstructive apnea, normal breaths, another obstructive apnea, and in the presence of profound desaturations. So this was a very severe obstructive sleep apnea. This is 120 seconds, as you can see here, of sleep. And the patient already had 4, and there's another one coming here, 5. And as you know, more than 1 is obstructive apnea-hypopnea index, more than 1 per hour is abnormal. About 5 is moderate, and about 10 is severe obstructive sleep apnea in children. So this was a very severe obstructive sleep apnea in a child who actually had some craniofacial abnormality. So hypopnea rule change in 2007, it was 50% reduction in airflow, but currently it's greater than 30% reduction in airflow. So there is some decreased amount of breathing, but it's not enough to score in itself. Of course, it always needs to last 2 breaths, but it needs to be also associated with a desaturation of 3% or an arousal. So hypopneas are decreased amount of breath, and which has a consequence, physiological consequence, such as desaturation or an arousal. So here you see there's a decrease by 30% followed by a desaturation, another one followed by desaturation, another one. So sometimes children do not have overt obstructive apneas, but many hypopneas. So when we calculate the apnea-hypopnea index, we always include the hypopneas as well. So here's a child with hypopnea, desaturation, obstructive apnea, hypopnea, hypopnea. So that's usually the pattern we see, especially during REM sleep. Mixed apnea mixed apneas contain both central portions, so there's no flow, And then when you look at the ribcage and abdominal movements, for portion of the apnea, there is no movement in ribcage and abdomen, followed by a movement. So in adults, this is the rule, but in children, it doesn't matter. First, it can be the obstructive portion, followed by the central portion, or vice versa. So that was part of the question as well. And these are counted as obstructive apnea-hypopnea index. So these are considered as obstructive events. So when we score all these respiratory events, we then calculate the number of obstructive, mixed, central apneas and indexes. And this is apnea index, events per hour. We also calculate the number of hypopneas. And I didn't touch here, again, in interest of time and the number of slides, but in children, and in adults too, you can also separate hypopneas as obstructive or central. Sometimes it's very helpful, but that requires another scoring. Like you look at the paradoxical breathing, you look at the snoring, and so forth. And then you calculate eventually the number of apneas and hypopneas per hour. And for the purposes of obstructive sleep apnea diagnosis, you calculate the obstructive apnea-hypopnea index. And this is how you base your diagnosis and treatment plans. You look at the snoring, you look at the oxygen desaturation index per hour. You also look at the minimum and average saturation. And hypoventilation is calculated as defined as the greater than 25% of the total sleep time that's spent with carbon dioxide greater than 50 millimeter mercury. And in the question it was 5%. And this definition is also questioned and challenged by French team. For example, they use sometimes 2 or 5% of the total sleep time spent with CO2 greater than 50 millimeter mercury. We are not sure the consequence, how the percentage of hypoventilation cause consequences in children. So that's still a debate. So finally, before we go to questions, we'll look at the normal values for pediatric sleep, both sleep parameters and the respiratory parameters. So we already talked about sleep efficiency is around 89%. And good news is that in children with obstructive sleep apnea, the sleep architecture is quite similar to the controls. So this was again an older study, but I quite like it because there are not many studies like that showing that obstructive sleep apnea controls have similar sleep efficiency and similar sleep stage time spent in each sleep state. So, and we already reviewed that. When we look at the normal polysomnography values in children, it gets a little bit complicated because these are the older studies before the American Academy of Sleep Medicine rules came about. But suffice to say that apnea-hypopnea index and obstructive apnea index are very low in otherwise normal children. So this is a summary of 4 studies looking at the normal values in children. There are some newer studies, but they confirm the same findings. So apnea-hypopnea index is usually less than 1 in otherwise normal children. But you look at the ages here. So newborns have higher values of obstructive sleep apneas, central apneas. So these are for children older than 1 year of age. And again, children usually have saturation, even the lowest saturation as low, maybe 90s. So low saturations are very unusual as well in otherwise normal children. So these are the values that we base our treatment in children with snoring and sleep disordered breathing symptoms. Which brings us to a case, and this is an 8-year-old girl with asthma, snoring, gasping, mouth breathing, and restless sleep. Her BMI is quite high and she has tonsillar hypertrophy. And her polysomnography shows severe OSA with obstructive apnea-hypopnea index of 31 with a minimum saturation grade less than 85, and the percent time span greater than 50 millimeter mercury of carbon dioxide is 8%, so not quite hyperventilation, but maybe quite high. So what would be your first recommendation for treatment? So this will also see if you were listening to me yesterday when we were doing the sleep talk. Watchful waiting, adenotonsillectomy, CPAP, nasal steroids, and weight loss. Okay, so the first and the most people answered adenotonsillectomy, but I think there's no one true answer here, and I think we can talk about those. So I would choose adenotonsillectomy also. Some studies show that children with obesity and hypertrophic tonsils still respond to adenotonsillectomy. It's just there is more residual obstructive sleep apnea in children who are obese, as we reviewed yesterday. So as the positive response cure rate changes from 30% of 50% to maybe a little bit more than that, but not much more. And some studies show even less response, especially the cure rates. Usually improves, so it's important to consider adenotonsillectomy, even in obese children, children with neuromuscular disease, or children with Down syndrome. It's just important to know that the response may not be 100%. So a lot of people in the audience also chose weight loss. I totally agree with that. This should be in addition to the adenotonsillectomy. So their adenotonsillar hypertrophy obstructive sleep apnea causes increased activity, and the increased activity is associated with weight loss, so the children cannot gain weight. And the recent studies also confirm that all children gain weight after adenotonsillectomy. So if they had failure to try, it's great news, especially for parents, everybody's happy. But if the child is already obese, they may actually gain more weight, which is again a cause for obstructive sleep apnea. So they may actually either have persistent or recurrent obstructive sleep apnea. So I think it's important to have a combined effort here with adenotonsillectomy and weight loss. So she had marked symptom relief after adenotonsillectomy. Repeat polysomnography showed, so this girl was lucky, obstructive apnea-hypopnea index of 3, so which is mildly abnormal. There were no desaturations or hypercapnia, so great news. Then what would be your recommendation? A CPAP, nasal steroid and or Montelukast, so this is an inflammatory disease, weight management, anti-inflammatory treatment and weight management, or watchful waiting. There's a really nice study published a couple of years ago in European Respiratory Journal from Spain, which showed that they looked at obese children from community, and around more than 50% had obstructive sleep apnea, and the ones who didn't obstructive sleep apnea to follow up developed obstructive sleep apnea, especially they kept increasing their weight. And adenotonsillectomy did not cure the obstructive sleep apnea. Okay, so weight management and anti-inflammatory treatment and weight management were the answers that were marked the most. So Definitely agree with weight management. Do we need to add anti-inflammatory treatment? There are some case series showing that anti-inflammatory treatment with nasal steroids and or montelukast decreased residual obstructive sleep apnea in children. They are less successful in obese children. So maybe the audience read that the study in particular, but maybe still worth trying. So nasal steroids especially have been used in mild residual obstructive sleep apnea and have been found quite useful. So I will finish with this question, and then I'll try to answer some questions the audience have. Which of the following describes the respiratory event below? Obstructive apnea, obstructive hypopnea, central apnea, central hypopnea. So you look at, thank you, Hassan. Hassan said, thanks, it's a great conference. Thank you, appreciated the feedback. So you look at the flow. So this is the flow. There's no flow here. So you need to decide whether this is an apnea or hypopnea. And then you look at the chest and abdominal movements, and you decide whether there's any movement there or not. And the Untitled CO2 also shows a little bit, there's a lag, but there is a flattening of the Untitled CO2 also. And then you also look at the saturation, whether the saturation decreased or not, because we don't quite know what the length here, but I can confirm it's more than 2 breathing cycles of that child. And the saturation went down to 87 following the event. Yes, so I agree with that answer. So this is a central apnea. So there is no flow. So this is not a hypopnea, but a central apnea. So apnea. So the apnea is defined as greater than 90% decrease in the flow, and hypopnea was greater than 30%. So we decide this is an apnea, and because it meets the length criteria. Then we decide if there is a central or obstructive. Since there is no movement in the chest and abdomen, then we decide this is a central apnea. Then we need to decide whether we can score it or not. There is no arousal following the apneic event. So not the arousal criteria, but does it meet the desaturation criteria by 3%? Yes. It meets this desaturation criteria, so we need to score this event as central apnea. So I want to thank you. Sorry, I had like more slides, but I want to thank you all for your attention, and I'll try to go through the questions now. Would it be possible to share with us the latest version of American Academy Scoring Manual? Unfortunately, this is copyrighted, so I'm not allowed to share. It's available online. And the question goes, can a neonate with recurrent apneas with no clear diagnosis from overcup indicated to undergo PCG? Yes, so there are actually new articles which published normal values for neonates, so they can definitely go undergo polysomnography. I answered the adult scoring, 13 years of age. Slides are available. I think Amy already replied to that. So what is the normal values for hypoventilation definition and saturation normal at moderate altitude? So great question. There are excellent studies done in, I think, in Colombia, looking at normal values at altitude for children. So they are low because of the hypobaric, hypoxic values. There are excellent articles on that, especially I think the Sleep Journal has them. And okay, so tonsil adenoids have been removed. Why add anti-inflammatories? Excellent question, agree with that. So these 2 studies did add to that. So sometimes there's residual residual lymphoid tissue, because when some children undergo drug-induced sleep endoscopy, DISE procedure, one of the reasons for recurrent or residual obstructive sleep apnea is residual tonsillar tissue. Sometimes adenoids grow back. And also remember, there's actually a systemic inflammation as well. So the leukotrienes are also high in the urine of these children. So it's important to have this anti-inflammatory, but I agree with that. But there are some studies actually showing that they have been successful. Okay, so for periodic breathing, another excellent question, thank you. The periodic breathing example did not have any associated desaturations. So you don't need an associated desaturation for periodic breathing scoring, but if there is within this periodic breathing, if there is a central apnea that actually meets the criteria for central apnea, you also score that, because when you look at the periodic breathing, you say the total sleep percent of periodic breathing in total sleep time. So this is how you decide whether it's normal or abnormal, but you also need to report central apneas. So within that periodic event, if there was a central apnea meeting the scoring criteria, you should definitely score that central apnea also. So the other types of sleep studies, so type 2 or type 3, really, the polygraphies, can be used for central apneas or obstructive apneas, all sleep diagnostic purposes. You just need to know the weaknesses, the advantages, and also the strengths. So for polygraphies, as maybe now you have a better understanding that you miss the hypopneas that are associated with arousal with polygraphy, because you don't have EEGs mostly with those polygraphy devices. Although there's a newer device, it's hard to do that at home, but you can do that in the hospital with EEG, then it will be helpful. And for arousals as well. For arousals and for also for the different types of staging sleep, you need the EEG, EOG, and the EMG. So if you don't have arousals, you will underestimate the number of central apneas associated with arousal, or number of hypopneas associated with arousal. So that's the weakness. There are some advantages, and there are some normal values reported for both children and for newborns for polygraphy as well. So I think we just have to make the best of whatever method we have. So what's the maximal we can take as normal for less than 3 months? Is it normal up to 19? So there are some normal studies that have been published. The latest was from Stephanie Davis from I believe North Carolina, but I don't think it was 19, so I need to look that up. In a child with obstructive apnea after the surgery of adenoid tonsillectomy, does PCG needs to be repeated to confirm? Or if clinical evaluation is good, there's no need to repeat. So in my practice, if there are no symptoms following adenoid tonsillectomy, we do not repeat polysomnography. It's recommended to be repeated by the academy only if there are residual symptoms, or if the child had severe obstructive sleep apnea, or if the child's at increased risk for residual obstructive sleep apnea. So like if the child is obese, if the child has craniofacial abnormalities. So I try to allude to that, as I would repeat clinically my practice, although it's recommended for children who are at risk for residual apnea. If there is a child who has syndrome like Down syndrome or Prader-Willi syndrome, where I know they are at increased risk, may not have symptoms, and they're also at increased risk for hypoventilation and central apnea. So I would repeat in those children, but not, otherwise healthy, maybe like with obesity or severe central apnea. However, they are also recommended, but I think this resource is very limited, even in developed countries. I think we need to be careful. There are many studies with wide ranges of severity criteria for respiratory events for neonates and infants. What would you consider as normal range in these ages, and when would you like to treat and what therapy? So we consider central apnea index greater than 5, and I think that's the last question also that I have received for treatment indication. So you know, that's what's recommended, central apnea index greater than 5. If it's like 4.5 and the child doesn't have significant symptoms, or it's 5.5 doesn't have significant symptoms, I think one of the things you can do is follow the child, give oxygen, but let's say you have a child who have obstructive events, and in addition to that, hypoventilation, so high CO2s, I think those are the children who need to be maybe investigated more, maybe congenital central hypoventilation syndrome or neuromuscular disease or some idiopathic hypoventilation syndromes. So for those children, I think I would recommend a sleep study. And if they are not responsive to oxygen, I would do a titration. So we just have discharged a baby who was 3 months of age, who had hypoventilation, who didn't turn out to be congenital central hypoventilation. So the genetic testing was negative and the child is improving, but the child was discharged home with a BiPAP. So I think that's a very clinical decision, but you need to be careful. And if the central apnea index is greater than 5, I think it's important to make sure that child gets MRI and CCHS testing. So I think, okay, what's the normal AHI with titration? Excellent question again. So we try to normalize the sleep study, but you know, trying to normalize it, if that requires very high pressures and the child doesn't tolerate it, and then you don't have any treatment options. So I think it's important to settle. So I would go with 5 if you're not able to normalize it. So below 5, I think would be a reasonable clinical level for apnea-hypopnea index with titration. That's what we try at least initially, and now you can always titrate up once the patient improves. I hope this is clear, but let me know, Pilar, if that's not clear. What level of, okay, so how do you interpret an AHI of more than 1 but with normal central and obstructive apnea index? You separate them. So in adults, they do not separate between central and obstructive apnea index. They use just AHI. In children, we use AHI for obstruction and central events. And I think this is useful because we do have a lot of children with, let's say, Down syndrome, Prader-Willi syndrome, or other sorts of central apnea syndromes, Chiari malformation, myelomeningocele. So I think it's important. But there are some new papers showing that children with obstructive sleep apnea also have increased number of central apneas, and then they do normalize or decrease after treatment with adenotonsillectomy. I still would be very careful with a child who has obstructive sleep apnea, but in addition, high central apnea index, and would still do some treatment, some investigations for this child. I hope this answers. So all the questions, I think we are fine now, and we'll end the session. I get this message from ERS. So I think maybe just one last question from Pilar. What are the general normal pressures in CPAP, I suppose, in relation with pathologies? So we can go up to 10, 12, it can go up to 15 in children. So I find it that after 10, 12, it becomes very uncomfortable. So those are the pressures that we use the most. If I start auto CPAP, I usually do 5 to 10 or 12. And then about that, we usually switch to BiPAP. How would you treat central size events following an arousal? So there is no distinction. This is a great question again. There's no distinction in the guidelines to whether it's after a SI or before a SI, but this is important. Some centers do not score it. Some centers score it based on the guideline, but we're trying to answer some of these central apnea questions with the new ERS task force paper. So hopefully we'll be able to answer a little bit more detail. Thank you for joining, everybody. I really appreciate your time and your input. This was really very helpful for me too. It was nice seeing you all, and I think we're good to end here. Bye.